guys for all coming out today, and we are going to talk about total joint arthroplasty today. So this is one way that Becky gets part of an afternoon off, is when we have one of these talks. So here at Great Plains Health, we're very fortunate to have an actual joint replacement program. So in the OR, we actually have dedicated joint teams, which is very important because those are patients, some of them have worked with us for years, but that really helps expedite our time. I saw a recent study that for every 10 to 15 minutes longer that a surgery takes, that increases your risk incrementally. So we really like to just move through a joint replacement. Sometimes patients will ask us, how long does it take? And they're surprised when we tell them, really, it's just about an hour to an hour and a half most of the time. So it actually goes pretty quickly because everybody knows exactly what they need to do, and we just move right through them. The other thing that you want is you want to have your joint replacement done at a high volume center, and we do joint replacements 2 to 4 days per week here, depending on the schedule. So every week they're being done most days of the week. That's, again, a very important thing. We also have our excellent navigator nurses for the joint program, Lindsay and Jill. So most of you, well, all of you will meet them at some point as you go through the planning for a joint replacement. And then we have a proven track record. We keep track of all these things. We have a very low infection rate and a very low revision rate. And Joe can get you the actual numbers, but they're very good. So that's another really important thing. So what is a total joint arthroplasty? Well, really, it should be talked about as a joint resurfacing. As soon as we say a total joint replacement, patients think that we just go chop, and slap this whole new thing in there. This is an x-ray of the knee from the side, and what we're really doing is we're just resurfacing the end of the femur, top of the tibia, and then it doesn't show up on the x-ray because it's plastic. Plastic doesn't show up, so the spacer here that's black, that's plastic, and then there's a plastic button, we call it, that's cemented to the undersurface of the patella. So we're really just resurfacing the different compartments of the knee or the shoulder. When we do that, we're just removing a minimal amount of underlying bone. It's really important to have a joint preserving replacement in terms of preserving all the bone possible. When we say total knee arthroplasty, we're just use that term because that indicates that we're replacing all 3 compartments. So patellofemoral, and then we'll see on the next slide, medial and lateral. And this is a standing x-ray. Pretty much everybody that comes to us for knee pain will get this x-ray, a standing x-ray, so that we actually are looking at how much cartilage they have left. That's what we talk about in terms of the tread on the tire that they have remaining. So this patient just has very small, what we call marginal osteophytes that we're just being able to see here and here. So this patient probably does not need a joint replacement. They still have pretty good alignment, pretty good joint spaces, reasonable tread on their tire, so to speak. So when we do a resurfacing or a joint replacement, this is an x-ray of the left shoulder. Initially, it involves removal of all the bone spurs or the osteophytes. So this is a large, very typical osteophyte that we see in the shoulder. We call it a goat's beard osteophyte. We'll see a picture intraoperatively of a really large one of these. Here's another example of the bone spurs forming on the top of the shoulder, and then you can see that there's just no space between the ball and the socket. So different than that last set of knee x-rays that we saw where there was a good space. In this shoulder, there's hardly any space. So when a patient comes to us with this x-ray, if they're medically healthy enough, this patient is probably going to need a joint replacement. And here's, unfortunately, a classic set of knee x-rays that we see all the time. If you remember that other x-ray where there was a space between the femur and the tibia and pretty, what we call neutral alignment, this patient is very bow-legged. The technical term for that is varus alignment, and you can see that there's no space between tibia, so that's the classic bone on bone. You can see as that happens that the femur actually starts to sublux a little bit or shift on the tibia. This is a very painful set of knees. So we can try an injection in this situation, but this patient, if they're healthy enough, is probably going to be asking us to do a knee replacement. So looking at a model, this is a model from Stryker of the actual components that we use. So you can see from the side that we're just making these real precise bone cuts across the end of the femur, across the top of the tibia, and then we're just resurfacing the end of the femur and the top of the tibia. Here's those three components. All this research, all these billions and billions of dollars that are spent on developing these things boils down to, in the knee, just three components. So there's a tremendous amount of research spent on the radius of curvature and how that actually changes in the different parts of the component. But there's just a femoral component, cobalt chrome. On the tibial side, this is titanium because it transmits the stress to the bone very similarly to the way that bone acts. So it has almost the same, what we call modulus of elasticity. That's a big fancy term for it. Just has about the same stiffness as bone. So titanium for a lot of our implants and things is one of the metals that's used. And then this is the plastic spacer that we saw snapped into the tibia. This is why every few years you come back to us and have us check your joint. We get new x-rays, because if we can catch the wear when it's just worn into this tibial tray, we can go in and just change that out, and we don't have to remove the metal components from the bone, which is a lot more work. So, and that's true in the case of the hip or knee classically. And then this is just a model again of the implants. You can see how they just resurface the end of the femur and the tibia. They're just taking the place of what would be the worn out cartilage, which is shown here as blue on the model. So blue on the undersurface of the patella, blue on the end of the femur. What a patient feels when they feel the front of their leg is still them. So it's still your own quadricep, still your own patellar tendon. This half of your patella is still you. We've just taken off, for instance, 10 millimeters of the undersurface of the patella. It takes a while for your swelling to go down so that you can actually feel the bone, but it's still you. These ligaments on the side are still yours. So that's why we tell patients we may not be able to get rid of every bit of your pain after a joint replacement, because your soft tissues are still you. So you can still get a tendonitis. If you trip and slip on the snow hard enough, you can still tear a ligament. So it really should be thought of as just a new set of tires, a new set of tread on your tires. And then this is a patient. You can see this knee is now nice and straight. This is a standing view looking back at us. So their left knee obviously has been resurfaced, nice and straight. Right knee, still very bow-legged, still bone on bone. So one done, one to go. And we just warn patients, if they do them in a staged fashion for a while, and when their family watches them from behind, it's very obvious they have one straight leg, one curved leg, until they get the other one done. And then switching gears a little bit, on a hip, who gets a hip replacement. This is a little lady in her 80s that I replaced her hip on in 2011 on the left. I don't know how she's been putting up with this hip, but you can just see, you know, it's not rocket science to diagnose this. The femoral head is completely flattened. There's no space between the femoral head and the socket, and the femoral head actually before was down here, and it's just gradually slipped up and out. So this is a painful hip. Some of these patients, when they come in, their hip will actually squeak. When Becky or Angie puts them in a room and they try to get up from a chair, sometimes it will audibly squeak. So that's a very worn out joint. And then here's what that looks like after she has her second new hip replaced. So the post-op care for hip and knee replacements, they're allowed to wait or is tolerated. We actually get graded on whether the patient patients get up the day of surgery, so that's one of the things on our scorecards. The nurses get them up the day they've had surgery, at least to the restroom. PT 2 to 3 times per week for 4 weeks. A lot of our patients are swimmers. We'd love to have them get back in the pool, but their incision needs to be healed. So that's usually 2 to 4 weeks. Take your staples out at 2 weeks usually, and they can get back into the pool usually about a week after that. And then golf, biking, horseback riding as balance and gait allow. It's interesting how many of our patients want to know when they can get back on a horse. So a lot of our patients are farmers and ranchers. Obviously, it's partially age dependent. If they're 75 or 80, they may not be back on a horse as quickly as if they're 55 or 60. But the right answer is it has to be a really well broken horse, and they can be back on as soon as they're able to get their foot into a stirrup safely. And again, shouldn't be riding a horse that's not very well broken. Things can still happen, but you at least want to stack the odds in your favor. So total shoulder replacements. One of the things that patients want to know is, what is the difference between an anatomical and a reverse shoulder replacement? So this is an MRI of a right shoulder, and this patient, we can see the deltoid here. So this big muscle on the outside, this big fleshy muscle, is what a reverse shoulder replacement relies on to be able to lift our arm up. An anatomical shoulder replacement, that just means that we resurface the humeral head, we put a new ball right where the old ball was, new socket right where the old socket was, and we're relying on an intact rotator cuff here to keep the new ball against the new socket. If you don't have this structure intact, then you can imagine that the humeral head just slides up off the socket, and we'll see some examples of that in just a second. So this is a cadaver, a picture of a cadaver specimen. This is the front of the shoulder here, top and back. So you can see this person's rotator cuff was completely intact. So subscapularis, this is the part that tears most frequently. So this is what I spend a tremendous amount of time arthroscopically fixing our superior cuff tears. Sometimes the subscapularis will be involved, but you can see how it just surrounds the ball and keeps it in place against the socket over here, which we can't see. So a patient that needs a reverse shoulder replacement, all this tissue from here to here is gone. We'll see a picture of that on an arthroscopic image, and the image that we'll look at is from the same perspective where we're looking down on the shoulder and just seeing a massive tear that's not repairable. Those are the patients when they get arthritis as well, and it's symptomatic. Those are the patients that need a reverse shoulder replacement. So talking again about the bone spurs, or the technical term is osteophytes. This is a right shoulder. This is huge. I mean, this was about the size of an egg or a small lemon. This big bone spur just projecting off the front of the ball. This is the remnants of the worn out cartilage on the humeral head. So these patients, when they come in and we examine them, the shoulder just literally makes noise as they move it back and forth. And you can imagine how much this just blocks the range of motion. There's just a mechanical hard stop. They can't move their shoulder past that point. So the first part of the procedure is removing all those so that we can get down to the normal anatomy and then start working on that. And this is an example of a smaller osteophyte intraoperatively. You can see here we've already started to remove it. We have this that we're going to remove, and then our cutting jigs will fit on the front of the humerus so that we can go ahead and remove the remainder of the worn out cartilage. You can see none of this is normal cartilage over here, but these are just an example of the bone spurs that form as our body tries to redistribute that stress over a larger surface area. So an anatomical shoulder replacement, this is the model for that. We put a new ball right where the old ball was, put a new socket right where the old socket was, and then we rely on that intact rotator cuff to hold the two together, because there's nothing else really holding those together. So that's an example of an anatomical shoulder replacement. This is what it looks like on their post-op x-ray. New ball right where the old ball was on a short stem. This is just a metal, it's a special metal post that goes into a drill hole on the glenoid side, and then again, it's an all plastic glenoid, so it doesn't show up except for the metal post that anchors it into the bone. So that's the anatomical shoulder replacement. And again, this is a patient that needed both sides done, left side's done. These are the big bone spurs on the right shoulder, worn out joint spaces, the intact rotator cuff on their MRI, and we can tell, we get a hint that that's the case on their plain x-ray because the humeral head is still against the socket. The two are worn out, but the humeral head hasn't slid up off the socket, and then we confirm that on the MRI. And so this is what we hope all of our patients can do afterwards. Having said that, that's what we like, but in the case of shoulders and knees in particular, the best predictor of your post-op range of motion is your pre-op range of motion. So if a patient comes to us and they can only lift their arm up to here and it's because of a mechanical block, sometimes that's where we'll do pre-physical therapy and just have them stretch as much as possible. If we can get another, up to 130 degrees, then they will have a lot easier time regaining that range of motion afterwards. We always tell the patients the components will have the potential for full range of motion, but if you go into the surgery really stiff for a knee or a shoulder, you're gonna have to stretch things out that haven't moved normally for sometimes years. And so our components for a knee replacement will do 140 degrees of flexion. If a patient only has 90 degrees of flexion preoperatively, they're gonna really have to work to get a few more degrees out postoperatively. So, and that's borne out in studies. Certainly, any surgeon's practice, best predictor of post-op range of motion is your pre-op range of motion. So this is what actually a reverse total shoulder replacement looks like. So it's called a reverse for a reason. So we put a ball where the socket was and a socket where the ball was, and that allows this to act as a fulcrum for the humerus to move around. And so we use that when you have a deficient rotator cuff, and that's been a real lifesaver. This was developed in France. Just over the course of my career, when we started out, we did not have that option for patients. So if they had a large rotator cuff tear that wasn't repairable in severe arthritis, there weren't that many options until the reverse shoulder replacement came out. And now we use it not infrequently. So again, intact rotator cuff. If you don't have an intact rotator cuff, and this is an illustration of that, often there's still some rotator cuff tissue low down on the humeral head, but if the whole top part's gone, then the deltoid, this big fleshy muscle here, just pulls up the humeral head right off the socket. And so we'll see an x-ray of an example of that. You can also imagine that if we put the ball here and a socket over here, so there's a stable fulcrum for the range of motion, then all of a sudden the deltoid can act to lift the arm up for the patient and substitute for the rotator cuff. And sometimes they just have dramatic improvements in range of motion because often their passive motion is good, but they just don't have the motor to get their arm up into that position. And so here's an x-ray of a patient. Long-standing massive rotator cuff tear. This is what we call rotator cuff arthropathy, where you can see there's about a 50% mismatch between the humeral head and the socket. So this humeral head is sitting clear up underneath the acromion. It's worn a big groove in the top of the socket. All this should be sitting clear down here on the socket. So this is a very painful limited range of motion situation. And this is what that looks like arthroscopically. This patient's rotator cuff here, this is looking down on the shoulder like we saw in the cadaver specimen. So this is the greater tuberosity here, looking down into the socket. These are the remnants of the rotator cuff here. If this is not repairable, or if we repair it, but then it re-tears and they have this gaping hole, then most of those patients, the best option will be a reverse shoulder replacement. And so this is how those patients present to us with what we call pseudoparalysis. So we say pseudoparalysis because they do not have an interruption to the nerves to that arm. They can still feel normally, they can move their fingers, their wrists normally, but they just have no superior cuff function. The patient's deltoid is still intact, this muscle here, but without a stable fulcrum, it doesn't work normally. And so we just see the humeral head slide right up off the socket and have this real characteristic appearance when they try to lift their arm up. So, and then this is just part of the planning steps that we go through, where we take a CT scan of the shoulder, that gets sent off to the company that developed this software so that we can choose right where to put the base plate that the new ball snaps into, and then we can get it fitted into the best bone, because often these patients have very severe wear on the socket side too. So this is really an important step, a very helpful step for us. And we actually generate this kind of a model for each and every patient for our total shoulder replacements. This is sterile. This goes to the back table with us so that we can intraoperatively compare what we're seeing of the patient's anatomy, because we have all these other tissues around it with the actual model of their bone. This is the guide that we'll see that snaps onto the face of this. And then these holes are for a guide pin that we then drill into the remaining socket bone, and then we ream off of that, and then that's the basis for our first screw, which we'll see right here. So that guide pin goes right where this screw is, so that we can make certain that we have that in the very best bone, and then the base plate gets put onto the bone, the new glenosphere gets snapped into that, and then the new socket goes over where the ball used to be. So this is a reverse shoulder replacement. You remember how that patient's humeral head was sitting clear up here before? So now it's been brought down and linked to the stable fulcrum for range of motion. We can see the outline of the deltoid here. That's this gray line. So then that big muscle then around that stable fulcrum can allow them to lift their arm up. So it's really just a huge innovation, just really over the last 10 years. And as everybody's experience gets better and better with it, and the implants get better and better, the number of reverse shoulder replacements is going up exponentially, because there's so many patients that fall into that category. So the post-op care for shoulder replacement, the Medicare rules are actually that you're supposed to stay in the hospital one night. That's hopefully going to change, because of all the joint replacements, the shoulder replacement is mobile. So they're the ones that would have the easiest time potentially going home the same day. Currently for Medicare, you have to stay in the hospital one night, PT once or twice per week for 4 weeks, generally no lifting more than a pound or 2 for 6 weeks, no golf or swimming type activities for 2 to 3 months, and then you can start resuming pretty much those things. So gentle active range of motion is tolerated. We do avoid external rotation more than 45 degrees with the arm abducted. So for the first 6 weeks, you just want to come to here, the arm at your side, just about out to here. Our physical therapists are our eyes and ears. They're helping the patients not go beyond those things as they go through the first 6 weeks. And that's because incisions on the front of the shoulder, and then we go through the front part of what's left of the rotator cuff, and then we repair that at the end of the procedure, and we really do not want that to re-tear. It's very hard to refix. And then sling for 4 to 6 weeks post-op when you're out in the community. At home, you can slip your arm out of that. We have you start bending your elbow right away. That starts the day of surgery if at all possible. Pre-op planning for all joint arthroplasties. This is where Jill and Lindsay and Angie and Becky and all the nurses help us out tremendously. We're checking all these things for the patient. So their diabetic control has to be very good. Their hemoglobin A1C should be less than 8. If it's above 8, then your risk for an infection goes way up. The big thing that we dread after a total joint replacement, if you get a deep infection, that typically means we have to take it out, temporary spacer, several weeks of IV antibiotics before we can do a new one. It's no fun for the patient. It's no fun for us either. So if at all possible, we ask the patients to stop all nicotine products or dramatically reduce their intake. Any nicotine interferes with your immune system. It also interferes with incorporation of the components into the bone. It's dose dependent, so if a patient can go from a pack per day to a half a pack per day, that's 50% less of that effect, we'll take it. We would love everybody to stop, but if they can go from a pack to a half a pack, if they can go, it's amazing how many people chew a can of chewing tobacco a day. So if we can go from 1 can a day to a can every few days or a week, then we just have 80% less nicotine, for instance, in their system. Ibuprofen and naproxen can also interfere with that bone incorporation. So preoperatively, you need to stop that a week beforehand because it can make you bleed worse. Post-operatively, we like you to stop it because it helps facilitate the incorporation of the bone into those components. Pretty much all the components that we've shown for the shoulder and for the hip are press fit, and so your body has to grow into those to have stable fixation. And then we really shoot for a body mass index of less than 40 if at all possible. If a patient's uncertain what their body mass index is, there's all these calculators on the internet. You can just Google body mass BMI calculator, plug in your height and your weight, and it'll give you a number. And we check that in clinic pretty much at every patient visit. And the risks of surgery, we touched on those a little bit. Bleeding, that's why we stop aspirin, stop all the other blood thinners a week before the surgery, including Advil and Aleve. If you have a bleeding event into a joint and we have to take you back to the OR and wash it out, then your risk for an infection goes from like 0.5% up to like 5 to 8%. So we really just want to do everything we can to not have those bleeding events. The rupture of the subscapularis repair, that's what I was referring to on the shoulder. That's very hard to refix. So that's why for that first 6 weeks, your motion is within certain planes. Then we can start advancing it as tolerated. Possible need, well, let's go to deep venous thrombosis. We pretty much just use aspirin now. Aspirin more and more has been proven to be a safe and effective agent. It doesn't have the incidence of these bleeding events into joints that some of the others will have, Lovenox or Eliquis. So if at all possible, we just go to aspirin post-operatively. It's cheap, we don't have to check pro times, and it's been proven to be as efficacious as what we call some of the more potent anticoagulants. Possible need for revision. This was a patient whose knee I replaced 12 years ago, and he unfortunately got an infection elsewhere on the leg that seeded his joint, and so we had to take out his knee replacement from an infection elsewhere, but it gave us a chance to look at his tibial polyethylene, so you can see just a little bit of wear here in the track from the femur and here, but this was after 12 years, and this guy weighed over 200 pounds. So the patients that I replaced 18, 19, 20 years ago, I'm seeing hardly any of those patients back to have their polyethylene spacer changed. So that's really good news, and that's how we want it to be. So the risk of revision is there, but if you use it sensibly, then it's really pretty low. Periprosthetic fracture, we just warn patients, if you fall hard enough to have broken your hip or your shoulder or a knee anyway, you can still break around a component. So balance is really important. A joint replacement does not make you bulletproof, unfortunately. And then of course there can be other things like heart attacks, and that's why we send you to your family doctor, to your internist, get you cleared preoperatively to try to minimize those risks. So this was an interesting study from the Alzheimer's Association conference in LA just this year. They looked at the risk factors for dementia, and if we eat a diet high in fat, sugar, and salt, and do not engage in regular physical activity or smoke cigarettes or consume excess alcohol, then our risk for dementia goes way up. So we can control that. Even if we have positive family history for it, we're at least 30% less likely if we do these things. And one of the really important parts of that is just regular physical activity, just walking. So that's part of the reason why a joint replacement is so important for many of our patients, so they can just get out and move. This was it's a little busy. This was some findings from the British Journal of Sports Medicine, an article dedicated to walking and health. If you see somebody walking really fast in front of you, just realize that in this study what they found is that if you're an average pace walker, you have a 46% reduction in risk of death from a cardiovascular cause. A fast-paced walker, it's hard to say, has a 53% risk reduction. So just walking and walking fast can dramatically decrease our risk for a cardiovascular event. So really important when a patient goes from barely being able to get out of a chair to being able to walk several blocks and then gradually advance that is very important. So this is a physician's work that I recommend to patients all the time. He has a couple books, Eat to Live, and The End of Dieting. He practices back east. I think these are really important books, especially this one probably because he looks at a lot of the fad diets out there, including the keto diet. There's a ton of misinformation out there. He looks at the best studies, and so this is a resource we try to refer our patients to all the time. He does have talks on YouTube as well under Eat to Live, so if a patient's not a reader or a visual learner, we talk to them about just looking his talks up on YouTube, but very helpful. So why do we do all this? Well, so we can get out, maybe ride some motorcycles, go fishing. Maybe all you want to do is chase your little dogs around. These little guys don't look like they could get in much trouble. I've shown this slide before, but this is what happens when they get into porcupines. So maybe you have to chase them down to get all those quills out. This is my dad in the back with a big grin on his face. He's had both of his hips replaced and is still able to ride horses. 2 years ago, he climbed Mount Sneffels, a 14er by himself. So we want patients to be active afterwards. Thank you very much. Are there any questions? So, we didn't show anything too gruesome, right?
Don't take any pictures when you work on it.
We don't have to.
So any questions?